Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. We are from Group 6. So me, Nur Hasina binti Nik Sabri, and my teammates, Sister Alia, Sister Shakira, and Brother Jibril will present to you about peripheral arterial disease. So we begin with case presentation. So first, we will start with case presentation. So the chief complaint is Puan Kunjama, a 76-year-old Indian lady, came to suspect due to non-healing lesion for 1 month's duration. For the history of presenting illness, the lesion was at the middle part of the leg, near the heel. The color of the lesion is blackish. She stated that the lesion may be due to trauma from stepping on tree branches. The pain on the lesion is dull in nature. The size of the lesion was gradually increasing in size, no exacerbating and relieving factor for the lesion. It was associated with pain on the leg surrounding the lesion. The pain was severe, sharp, but not worse at the night. 10 years ago, she complained of pain on both lower limbs, starting from knee and below when walking more than 100 meters. The pain was cramping in nature. She need to stop from walking for about 5 minutes and can continue back. The pain was relieved when she massaged her leg. The pain was also associated with blackish discoloration on both lower limbs, starting from below the knee. 2 months ago, she stated to have rest pain on her both lower limbs. Otherwise, there were no fever, palpitation, and shortness of breath. For the past medical history, she had type 2 diabetes mellitus for about 25 years and compliant to medication. Same goes to hypertension. For drug history, she took diabetes mellitus medication and insulin, and also hypertension medication. For drug allergy, she allergic to bactrim. For family history, she has a familial diabetes mellitus. For social history, she was a retired teacher, married, and had 2 children. On general examination, the patient was alert, conscious, sit on her bed in painful condition, no respiratory distress, and no cardiac sick. There was no jaundice, pallor, or cyanosis. IV cannulation was connected to her left dorsal hand. On lower limb inspection, there is lesion at left leg medial to heel, measuring about 4 cm times 4 cm. There is blackish at the edge of the lesion. Hyperpigmentation were also noted at her both lower limbs, starting below the knee to the toe. On palpation, the dorsalis pedis and popliteal artery were not felt, but there is presence of femoral artery. The temperature of both lower limbs were cold. On investigation, eosinophil count is high with 1.22, lymphocyte low 1.56, CRP high 3.33, and tissue culture is Citrobacter cocci. So now we will go for acute limb ischemia. So acute limb ischemia occur when there is sudden decrease in limb perfusion that causes a potential threat to viability of the limb in patients who present within 2 weeks of acute event. So this is an emergency case, and knowing to spot it first is very important. The prevalence is 1 in 6,000 of the population, and the common causes are due to arterial embolism, acute thrombosis, and trauma. So now, we will talk about the causes of acute limb ischemia. So the most common causes of acute limb ischemia is arterial embolism. This contributes to 60 to 80% of cases, and usually it affects the lower limb. Sources of emboli can be divided into 2, which are cardiac and non-cardiac source. For cardiac origin, 70% occur from atrial fibrillation, where the rhythm is not treated properly with irregular rhythm, which means atria not contracting properly and forming atrial thrombus. While 20% cases due to post-myocardial infarction, where ventricle not contract properly and forming ventricle thrombus. And the remaining is come from small proportion to prosthetic heart valve who are not receiving anticoagulant therapy. For non-cardiac causes, Embolism can occur from atherosclerotic plaque when there is catheterization to place stent and it dislodges some of the plaque and the plaque down to the arterial circulation. And thrombus from aneurysm is because in the aneurysm is not getting a normal blood flow and it develops thrombus. Most common sites for emboli to lodge are at bifurcation of femoral artery, trifurcation of popliteal artery, and it also occurs at upper limb region. Features to suggest arterial embolism as the cause of acute limb ischemia is when there is no previous history of intermittent claudication, or the patient maybe have atrial fibrillation or have recent myocardial infarction. Next, acute thrombosis may contribute to acute limb ischemia when the patient have pre-existing peripheral arterial disease like in situ thrombosis, and the features to suggest acute thrombosis are when the patient have previous history of intermittent claudication and no obvious source of emboli. So now, what are the difference between embolism and thrombosis? Basically, some symptoms will give hint to how we want to differentiate between these two things. In terms of severity, thrombosis is less severe because the progression of peripheral arterial disease will give some time for collateral to develop, while in embolus, the event is sudden. Next, patients with thrombosis have previous intermittent claudication, while embolism is not, and also bruits is present in thrombosis but not in embolism. So these are the clinical presentation of acute limb ischemia with pneumonia of 6 P's, which are pain, paralysis, pulseless, perishingly cold, pallor, and paraesthesia. For the explanation, the pain is occur at distal to occlusion and it was the earliest symptom. Next, pallor occur due to reduced perfusion to the affected site. After that, distal pulse to the occlusion will be absent and that can be confirmed by palpation or through Doppler ultrasound. And next, the skin of affected site will be perishing cold because lack of blood flow and heat loss. Lastly, tingling and numbness sensation indicating nerve ischemia, and there will be irreversible damage. So this is the picture of acute limb ischemia with mottling appearance and pallor foot. And these are also the picture on how we want to palpate the artery of lower limb. Now, we will go to the principal management of acute limb ischemia. So first, we need to do the initial assessment to look for the severity. First, we do the clinical evaluation using 6 P's and then we do the classification of limb viability. Actually, this classification is no need for you to remember. It was just a guide to see how severe of the disease. Next, we need to resuscitate the patient by giving IVSS, oxygen therapy, anticoagulant, and analgesia for the pain. After that, we do the imaging. The most accurate imaging is CT angiography, but due to emergency case, we proceed with the most suitable test, which is Doppler ultrasound. After that, we go for definitive treatment, and this depends on the viability of the limb. If the limb is still viable, we do catheter-directed thrombolysis, which is a minimally invasive procedure where thrombolytic agents will be directed to the site of the clot using a catheter under imaging guidance. Next, angioplasty is also a minimally invasive procedure that opens the blocked or narrowed arteries. Embolectomy is a surgical procedure to remove a blood clot that blocking the blood flow in blood vessel. And lastly is bypass surgery. And for threatened limb, it requires an immediate surgical. And lastly, primary amputation is needed for non-viable limb condition. So this is an image of what is Doppler ultrasound, and next we have CT angiography image. And then also I attached the picture of each procedure. So we have angioplasty, arterial embolectomy, catheter-directed thrombolysis, and artery bypass surgery. So you can see this picture to get the overview on how actually the procedure is work actually. So my last part, questions. So first, my question is why embolism usually affect lower limb rather than upper limb? And second, what are the complications if the treatment for acute limb ischemia is delayed?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, everyone. I am Nur Alia Maisara binti Askari, metric number 2211650, and I'm going to continue this presentation by presenting about the chronic limb ischemia. So, chronic limb ischemia can actually be divided into critical and non-critical limb ischemia. A non-critical limb ischemia is further subdivided into that which causes symptom, usually claudication, and that which is asymptomatic. So most common causes are usually atherosclerosis with gradually developing diffuse stenosis of the peripheral arteries, which will cause diminished blood supply to the lower limb. So, before we go deep into this topic, let's all do a recap about the pathogenesis of atherosclerosis. So, there are several key steps that occur in this pathogenesis. So, the first one are endothelial injury or dysfunctions. So, basically, there are damage to the endothelial lining of the arteries due to risk factors such as hypertension, smoking, diabetes, and elevated LDL cholesterol. So endothelial cells will become dysfunctional and increase the permeability and facilitating the migration of lipoprotein into the intimal layer of the vessel wall. The LDL will then penetrate the endothelium and accumulate in the intima. These LDL particles will then undergo oxidative modification, producing oxidized LDL, which is pro-inflammatory. Oxidized LDL then activates the endothelial cells, leading to expression of adhesion molecules like VCAM1 and ICAM1. These molecules are the ones that gonna attract the circulating melanocytes, which migrate into the intima and eventually differentiate into macrophage. Then, macrophage will engulf the oxidized LDL and form cells. These foam cells will aggregate to form a fatty streak, which is the earliest visible signs of the atherosclerosis. Cytokines and growth factors also released by macrophage will stimulate the proliferation and migration of smooth muscle cells from the media to the intima. The smooth muscle cell will then secrete extracellular matrix component, which is, for example, collagen, contributing to the plaque stability. The plaque grows through the continuous lipid deposition and inflammatory activity. A fibrous cap will form over the lipid core, which may stabilize the plaque. However, ongoing inflammation can weaken the fibrous cap by degrading the collagen and increase the risk of rupture. So when the rupture occurs, it will expose the thrombogenic material from the lipid core to the bloodstream and triggering thrombosis. This progressive plaque growth also can significantly narrow the arterial domain, restricting the blood flow. So first, let's look into the non-critical chronic limb ischemia, which usually presented with intermittent claudications. Intermittent claudication is usually characterized by pain on walking in the muscles of one or both calves. If the iliac arteries are also affected, then the pain also may be felt in the thigh and even in the buttocks. The pain comes on after a reasonably constant claudication distance and usually subsides rapidly and completely on cessation on walking. Resumption of walking will cause the pain to return. So the common classification systems includes the Fontaine's classification and Rutherford's classifications. Let's look into the Fontaine's first. So we have 4 stages here. The first one, stage 1, shows asymptomatic. Stage 2, a mild claudication, pain-free claudication more than 200 meter. 2B, moderate severe claudication less than 200 meter. Stage 3, ischemic rest pain, and stage 4, ulceration or gangrene. Next, for Rutherford classification, it is classified by grade and category. For grade 0, category 0 show asymptomatic. For grade 1, we have 3 categories, which are the first one show mild claudication, the second moderate claudication, and the third one is severe claudication. For grade 2, category 4 show ischemic rest pain, grade 3, category 5 minor tissue loss, and grade 4, category 6 show ulceration or gangrene. So let's take a look on the second picture here, over here. Okay, so this picture I will further explain in the next slide. On early stage, typically superficial femoral artery narrow at the adductor canal. Ankle pulse may be palpable but are diminished. Febrile can be heard at or below the stenosis. Ankle to brachial pressure will be normal at rest and reduced by exercise. For mild claudication, over the next few months or years, collateral vessels arise from profunda femoral artery enlarged to increase blood flow to lower leg, resulting in improvement of symptoms. The thrombotic occlusion of the superficial femoral artery will cause sudden deterioration in walking distance, and the ankle and popliteal pulse may be absent. For moderate claudication, the continued development of the collateral circulation could cause the symptom and walking distance improve. This phase will be stable for a few years, but without treatment and change in lifestyle, the atherosclerosis will progress to involve other segments such as profunda artery, iliac and tibial vessels. As the disease progresses further in severity and extent, symptoms are likely to worsen to a point where chronic limb ischemia will develop due to multi-level disease. Such patients will often go on to develop night or rest pain and are at risk of tissue loss. Next, for management or intermittent claudication, the first one we have risk factor modification. So 40% of peripheral vascular disease patients have significant coronary or cerebral arterial disease. The mainstay treatment is aggressive risk factor modification, which includes smoking cessation, oral statin treatment, do regular exercise, control of blood pressure and serum glucose, and lastly, antiplatelet therapy. As you guys can see at the table below shows the risk factors and association of the intermittent claudications. Next, we can also do endovascular treatment. So, balloon angioplasty with or without stenting has been used successfully in the iliac, femoral, popliteal, and crural arteries. It is usually performed under local anesthesia. The arterial lesion to be treated, stenosis or occlusion, is identified and crossed with a wire. A balloon catheter is introduced over the wire and the balloon inflated. This will enlarge the lumen by disrupting the atheromatous plaque. In occlusion and complex disease, metal stents may be deployed across the lesion to improve the patency and reduce the distal embolic complications. Sometimes, these balloons and stents are coated with drugs that reduce the arterial scarring that follows such intervention and can lead to restenosis and reocclusion. For surgery, it is only used for short distance claudication, and if there is severe lifestyle limitation and failure or unsuitability of endovascular treatment in the aortoiliac segments. Procedures available includes aorto bifemoral graft with 5-year patency of 90%, but carry 5 to 8% mortality and a risk of impotence. It is usually used for younger patients. The second one is femoral crossover bypass graft. It is used for isolated unilateral iliac disease with 90% of 1-year patency. Common femoral endarterectomy used for isolated common femoral disease. It shows good results and have a low complication rate. So next, let's move to the critical limb-threatening ischemia. Critical ischemia occurs when arterial insufficiency is so severe that it threatens the viability of foot or leg. This is formally defined by a European consensus document as follows, which include persistently recurring rest pain requiring regular analgesia for more than 2 weeks, or ulceration, or gangrene affecting the foot, plus an ankle systolic pressure of less than 50 mm mercury. So for ischemic rest pain, it is continuous unrelenting pain caused by severe ischemia. Unlike intermittent claudication that I have explained just now, rest pain occurs even without any activities and persists day and night. In most cases, walking capacity is severely limited or impossible. Actually, rest pain typically occurs at night, as at that time there will be low blood supply as patient is not in independent position and decreased blood pressure during sleep, which will wake the patient from sleep. At first, the pain may be relieved by hanging the limb out of the bed, but as the disease progresses, the patient has to get up and need to get a short walk to relieve the pain. If gangrene is present, the pain usually located at the junction of the living and dead tissue. And for this type of pain, strong analgesics are often required to relieve the pain. Gangrene can be defined as death of tissue, specifically due to inadequate blood supply. It occurs when arterial blood supply falls below that which is necessary to meet minimal metabolic requirements. So we have two types of gangrene, which are dry and wet. So let's take a look for the dry one first. So it is hard and dry texture, often has a clear demarcation between viable and necrotic tissues. It usually occurs in patients with atherosclerotic disease. For wet gangrene, it is moist, swollen, frequently blistered, and usually have bacterial infection and putrefaction occurs. The gangrene will spread proximately and often occurs in diabetics with decreased sensation and unrecognized trauma patients. Next, with ischemic ulceration, it is usually arise from minor traumatic wounds with poor healing, often painful, it does not bleed, but may discharge thin serous or purulent fluid. It is progress slowly, becoming deeper and larger, and may penetrate joints and cause severe pain during movement. So ischemic ulcers are usually found at the tips of the toes or fingers and over the pressure points. It is vary in size from small deep lesion a few millimeters across to large flat ulcers 10 cm or more wide on the lower leg. The ulcers are more often elliptical. The ulcer and the surrounding tissues are often very tender. Example, removing a dressing can cause exacerbation of the pain that can last for several hours. The surrounding tissues are usually cold because they are ischemic. Warm and healthy tissue may suggest another cause for the ulceration. The age of an ischemic ulcer is either punched out if there is no attempt at healing by the surrounding tissue, or sloping if the ulcer is beginning to heal. The skin at the edge of the ulcer is usually blue-gray color. So we came to the last segment for chronic limb ischemia, which are management for critical limb-threatening ischemia. So you guys can see in the box, we have several treatment options for chronic lower limb ischemia. Let's take a look in the critical ischemia section. So the first one, we have intravenous drug therapy such as prostacyclin. So how actually prostacyclin works to treat this critical ischemia? So prostacyclin and its analog are used in the treatment of CLTI due to their potent vasodilatory and antiplatelet effects. So prostacyclin will induce the relaxation of vascular smooth muscle, increasing the blood flow to the ischemic tissue. And at the same time, antiplatelet activity will inhibit the platelet aggregation, reducing the risk of microthrombi formation, which can exacerbate ischemia. The second one is lumbar sympathectomy, surgical or biphenyl injection. So lumbar sympathectomy actually used as a palliative treatment in selected cases of CLTI, particularly when revascularization is not feasible or as an adjunct therapy to improve the symptoms. Lumbar sympathectomy will eliminate the vasoconstrictive impulse, resulting in sustained vasodilation of the small blood vessel. By dilating arterioles and improving collateral circulation, it will enhance the blood supply to the ischemic tissue. The procedure may alleviate the ischemic rest pain by improving the oxygen delivery and possibly disrupting the pain pathways. Increased blood flow will also support healing of the ulcers and any ischemic lesions. So next for balloon angioplasty, this is an endovascular treatment. It is same as I have explained for the intermittent claudication. Next for reconstructive artery surgery, I will explain in the next slides. For amputation, Brother Gabriel will explain furthermore on that part. And lastly, palliative care, including appropriate analgesia such as opiates and morphine. So for principle of artery reconstruction, we have the first one, endarterectomy, which involves direct removal of atherosclerotic plaque and thrombus. However, it is rarely performed except at the carotid and femoral bifurcations. The next one is bypass grafting. For a surgical bypass operation to be successful in the long term, there are three conditions that must be fulfilled. So the first one, there must be high flow, high pressure blood entering the graft. The conduit must be suitable. The blood must have somewhere to go when it leaves the graft, outflow or runoff. And there are two main types of conduit are available, which are the first one, autogenous material, which is most commonly the ipsilateral grad saphenous vein, GSV, and the protestic material, and is most commonly expanded polytetrafluoroethylene, EPTFE or Decron. So in this slide, you guys can see there are two examples of the bypass graft. So the first picture shows the aortobifemoral bypass graft, a Decron bifurcation graft or prosthesis which used to bypass the aortoiliac segment when it is occluded, or stenos, or to replace it when aorta and iliac are aneurysmal. So the second picture here, you guys can see the techniques of arterial bypass for femoral popliteal grafting. In most bypass operation, the new conduit more or less follows course to original artery, so-called the anatomic bypass. Where this is not possible and or desirable, a so-called extra anatomic bypass can be inserted. For example, if only one iliac artery is blocked and the patient is unfit for abdominal surgery and unsuitable for intraluminal treatment, a femoral crossover graft can be performed. If both iliac arteries are occluded, then an axillobifemoral graft can be inserted. In general, the extra anatomic grafts do not have as good long-term patency as the anatomic aortoiliac reconstruction. However, they are lesser procedures and so the preferred option in high-risk patients or those that have limited life expectancy. So in this slide, you guys can see there are two pictures over here, which are, the first one is to show the femoral crossover graft, and the next one show the axillobifemoral bypass graft. So over here I have provided two questions that you guys might find out before our next session. Thank you for listening.
Hi everyone, my name is Nur Shakira Humaira binti Hakim. I'm gonna present to you about the aneurysm. So let's dive in. An aneurysm is actually derived from a Greek word means dilates. Therefore, the full definition of aneurysm is a localized dilatation of an artery. There are several risk factors that can increase the chance of getting aneurysm, which is modifiable and non-modifiable. For non-modifiable risk factor, number one is male. Male is affected 6 times more than female because female have higher estrogen level. This estrogen level helps in enhancing the endothelial function and also preserving the elasticity of the arterioles. Second is older age group. 50 years old and above will increase the chance of getting aneurysm. However, in young patients, there is rare case of getting aneurysm. And then we have family history of genetic defect in synthesis connective tissue, for example, Marfan syndrome and Ehlers-Danlos syndrome can cause aneurysm. Second is modifiable. Number one, hypertension. Hypertension will increase the pressure towards the arterial wall and can cause weaken of the arterial wall itself. And then smoking. Smoking can cause increase in oxidative stress and inflammation. This inflammation also can cause weakening in the arterial structure, in the arterial wall structure. And then hyperlipidemia. Hyperlipidemia can cause atherosclerosis, which is the most common causes of aneurysm itself. Okay. We can classify aneurysm into two, which is morphology and also site. For the morphology, it is described as true aneurysm and pseudoaneurysm. Pseudo means false aneurysm. True aneurysm must consist of involvement 3 layers, which is the tunica intima, tunica media, and tunica adventitia. And then this true aneurysm is subdivided into two structure, which is the falciform and saccular. Falciform means there is two bulging. When we draw a symmetrical line, there is two bulging on both sides. But in saccular, there's only one bulging in one side, which means another side is normal. So saccular is one of the example is Berry aneurysm that occur in a circle of Willis. This Berry aneurysm can cause a subarachnoid hemorrhage. So, true aneurysm is commonly caused by atherosclerosis. So, we move on to pseudoaneurysm. Pseudoaneurysm is not involving the layer, but is actually a breach, which means there is a hole in the layer, and then the blood accumulate in a connective tissue or in the tunica adventitia. So, it seems like there is a bulging. Seems like it is aneurysm. However, it is not, because it is not involve the layer. So this pseudoaneurysm can be caused by iatrogenic injury in surgical procedure. For the classification of aneurysm, we can classify it based on the anatomical site. And the most common anatomical site for aneurysm is aortic. And this aortic aneurysm can be divided into three parts, which is the abdominal aortic aneurysm, thoracic aortic aneurysm, and thoracoabdominal aortic aneurysm, which consists of abdominal and also the thoracic. So abdominal aortic aneurysm, 95% occur infrarenal, which means it occur inferior to the renal artery, and 15% of this can extend it down to the common iliac artery. For the measurement, anterior posterior diameter is equal or more than 3 cm. And then thoracic aortic aneurysm is divided into three parts, which is ascending aortic aneurysm, aortic arc aneurysm, descending aortic aneurysm. For ascending aortic aneurysm, it is asymptomatic and accidental finding during imaging. Sometimes patient can have symptom. For example, chest pain, dysphagia, hoarseness of voice, and it same goes to aortic arc aneurysm. Aortic arc aneurysm, patient also can have symptoms such as dysphagia, hoarseness of voice, and also back pain. And in aortic arc aneurysm, if there's atherosclerotic plaque, it can embolize to the brain and cause stroke. Okay, other than aortic aneurysm, we can also go through the peripheral aneurysm. And then in peripheral aneurysm, there's three most common one, which is the iliac aneurysm, femoral aneurysm, and also the popliteal aneurysm. In iliac aneurysm, 20% of this came from abdominal aortic aneurysm patient, and it extends into one or both common iliac artery. 1/3 of this can also extend to the internal iliac artery. So if you can see the pictures here, so this is the first picture is about the abdominal aortic aneurysm, and then the second picture is abdominal aortic aneurysm with bilateral common iliac artery, and then the third picture we have abdominal aortic aneurysm with internal iliac artery, and then we have femoral and popliteal. So here we can see that abdominal aortic aneurysm can extend to secondary aneurysm. Therefore, if we see any aneurysm in the femoral, in the popliteal, in the iliac, we need to do another imaging to rule out abdominal aortic aneurysm. So next is femoral aneurysm. Femoral aneurysm are divided into three parts, which is three part is the causes, which is iatrogenic, pseudoaneurysm. Non-specific aneurysm is true aneurysm, came from 10%, came from patient with abdominal aortic aneurysm, and anastomotic aneurysm. Lastly, popliteal aneurysm. For popliteal aneurysm, 20% of this came from abdominal aortic aneurysm and 50% are bilateral, means both have the same aneurysm but maybe delay in time. And then popliteal aneurysm can be complicated, which means popliteal aneurysm can be distal embolism and cause acute thrombosis. It can cause distal, it can derive emboli, and then it can cause acute thrombosis. Other than that, popliteal aneurysm can compress the popliteal vein and it can manifest the same symptom as deep vein thrombosis. So in this slide, we will discuss about the etiology of the aneurysm. So all of the etiology are root to the same causes, which is the degenerative of elastic and collagen fiber, because if this happen to be degenerate, it can be a weakening of the arterial wall. So it is divided into acquired and also congenital. In acquired, there's atherosclerosis and also infection. But in congenital, there is only one, which is the hereditary connective tissue disease. Infectious can be syphilis, salmonella, septic embolism of the endocarditis, and also prostatic graft infection. In hereditary connective tissue disease, it can be Marfan syndrome or Ehlers-Danlos syndrome. So how atherosclerosis cause aneurysm? So first of all, the initiation of the atherosclerosis itself and plaque formation, it can cause endothelial injury. So what happens if the endothelial injured? It can promote the inflammatory cells. What is inflammatory cells? The macrophage, the T cells. So this recruitment of the macrophage will go to the plaque formation, and then this macrophage will secrete pro-inflammatory cytokines and also MMP. What is MMP? MMP is matrix metalloproteinase. This MMP will degrade the extracellular matrix. So this cause the chronic inflammation and can cause weakness of the arterial wall. It comes to the second part, which is the wall degeneration and remodeling. Because of the overreactive MMP, it becomes that elastic and collagen fiber degrades and it remodel, which means it can be classification, and the medial part of the arterial wall can become necrosis, where the smooth muscle cells in the media undergo apoptosis, and also reducing collagen synthesis. And this situation can make the arterial wall become reduced in elasticity and contribute to fragility. So third part is hemodynamic stress. So when there's atherosclerosis, it becomes that there's wall tension will increase because of the turbulent blood flow. So when there's is increase in increased wall tension, but at the same time the wall become weakened, it can promote the dilatation. So that's how the aneurysm happen, because the wall itself weakened and the turbulent blood flow making it increase in wall tension. It becomes that the arterial wall can dilate so easy. So that's come to the fourth, where the aneurysm expand. So next is infectious. So infectious also can cause aneurysm, because infectious can cause inflammation, can cause necrosis, and can cause weakening of the arterial wall. So before this, it calls that mycotic aneurysm. So this mycotic aneurysm refers to fungal-like appearance, but typically it involves a bacterial pathogen. So source of infection can include hematogenous spread from distant infection, for example endocarditis, and then direct extension from adjacent infected tissue, and lastly trauma or iatrogenic injury introducing pathogen into the vessel's wall. So what is the common causative organism? Number one is bacteria. Bacteria, first Staphylococcus aureus. So this is the most common, especially in IVDU, intravenous drug user, and then Staphylococcus aureus. Staphylococcus aureus common in infective endocarditis, and then Salmonella often associated with gastroenteritis and septic bacteremia, and then E. coli and Pseudomonas aeruginosa, rare but can occur in immunocompromised individuals. And then second is fungal. Fungal can be caused by Candida and Aspergillus, seen in immunocompromised patients, for example, HIV, AIDS, and transplant recipient. So let's study about the clinical presentation of abdominal aortic aneurysm, because abdominal aortic aneurysm is the most common type of aneurysm. So first is asymptomatic, which is 60% of the patient. So it is incidental findings during physical examination, ultrasound and X-ray, which patient may not complain of having this kind of pain or tenderness around the abdominal region. So second part is symptomatic, which is 10%, pulsatile abdominal mass, central abdominal pain, back loin iliac fossa or groin pain. So there's only 10% patient will come with pain. And then if it emboli, it go to the artery, peripheral artery, it can cause leg pain or also ischemia. And if it large enough, it can compress the surrounding structure. For example, duodenum. It can cause intestinal obstruction and ureter. And sometimes it can also compress the inferior vena cava. And then number 3, ruptured abdominal aortic aneurysm, which is 30%. So this is emergency presentation, which is severe and sudden abdominal or back pain, hypotension, patient might have shock and syncope. So abdominal aortic aneurysm rupture usually to the retroperitoneum, sometimes into the surrounding structure and cause fistula. So how to do physical examination for aneurysm? So we divide it into 4 main part, which is the abdominal aortic aneurysm, the iliac artery aneurysm, femoral artery aneurysm, and popliteal aneurysm, because there's redundant in the physical examination. So first, inspection. For abdominal aortic aneurysm, we inspect at the upper umbilical and also the epigastric region. If iliac artery aneurysm, we inspect the distended at the iliac fossa or hypogastrium. If the femoral artery aneurysm, we inspect below the inguinal ligament and dilated vein seen in very thin patient. And then inspection of the popliteal aneurysm is at the popliteal fossa. Okay, palpation, see if there's expansile and expansile pulsation, which is firm and smooth surface, movable a little bit from side to side, tenderness, inflammatory change of aneurysm is stretching and likely to rupture. If it tenderness means that aneurysm are most likely to be complicated, which is it can goes to ruptured. And then we go to auscultation to see if there's presence of fluid over the mass. So for investigation of aneurysm, for non-ruptured abdominal aortic aneurysm, we can do ultrasonography and abdominal X-ray, but it's until the size of 5.5 centimeter, which is the diameter, or if the diameter expands 0.5 centimeter in a year. If this occur, we need to do operation. We do not have to do a follow-up routine check for the patient of non-ruptured abdominal aortic aneurysm. And then elective operation and ruptured abdominal aortic aneurysm, we do CT scan and we check for any inflammation of the aneurysm, surrounding arteries, renal arteries, and then we check for the secondary aneurysm, because abdominal aortic aneurysm can cause secondary aneurysm to the popliteal, femoral, and also the iliac, the common iliac artery. And then other abdominal pathology, for example, fistula. So this is a pictures of a 64-year-old Malay man complained of continuous aching back pain for 2 weeks. So this is at the A picture. This is a plain abdominal X-ray showing a huge abdominal aneurysm and also calcification along the arrow there's calcification. And then B, it shows CT scan of this patient, which is already have fistula on the third part of the duodenum. So from CT scan, we can see surrounding structure as well. Okay, how to manage patient of aneurysm? First, we stage the patient. If it's asymptomatic with small aneurysm, we only do surveillance with ultrasound or CT scans every 6 to 12 months and manage the risk factor. For example, the hypertension, the hyperlipidemia, we manage the modifiable risk factor. And then if it is symptomatic or large aneurysm, we do surgical repair, open or EVAR, depending on the size, symptom and the rupture risk. So what is open repair? It involves direct surgical exposure and placement of synthetic graft, preferred for young patient or complex cases unsuitable for endovascular technique. So endovascular aneurysm repair is minimal invasive because it using stent graft placed via the femoral artery access. So it goes into the femoral artery. So it do not need to open the abdominal. So reduce perioperative mobility and it is preferred in high risk patient. So that's all for open repair and EVAR. So rupture aneurysm, it is emergency surgical intervention. Usually we do open repair or EVAR in selected case. And post-operative care, imaging follow-up, for example CTA post EVAR, lifestyle changes, management of the comorbids, for example the hypertension itself. So here are some examples of open repair surgery. So as you can see, at the left side is a thrombus cast. This thrombus cast is in the abdominal aortic aneurysm. So at a different patient, at the middle pictures, this is an opening of an aneurysm sac. So this patient complained having back pain. So you can see there's a lot of blood, a lot of thrombus in the aneurysm itself. And then at the right side, this is a good example of ruptured abdominal aortic aneurysm. You can see there's a lot of blood coming out from the abdomen and through the all the peritoneum organ. So this is really invasive procedure. So this is a brief example of how EVA looks like. So EVA is endovascular aneurysm repair. So this is only consists of incision. So it costs minimal invasive procedure compared to open repair, because open repair can cause excessive bleeding. So first, how it occurs? First, there is incision at the right common femoral artery and insert guide wire with catheter, and then the cover part of the catheter will be removed and the stent of the graft will be open and then spring up and then it hooks below the renal artery, and then the old part of the catheter are removed and then they will hook at the aneurysm part and then go through the common iliac artery, the right common iliac artery. So there will be main body and then the lower limb, the limb which is at the common iliac artery, and then the surgeon will do another incision at the left common femoral artery and insert the left lower limb. It will be trumpeted, which means inserted inside the main body, which is already there in the aneurysm. So this is how they put stent without opening the abdomen. To conclude my presentation, here is 2 questions that you need to answer, which is what is the complication of untreated aneurysm except for rupture, and then why infrarenal aortic aneurysm is the most common in abdominal aortic aneurysm. So that's all for me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Jibril, and now I will discussing about the diabetic foot ulcer and also amputations. So let's begin. When discussing about diabetic foot ulcer are severe complications of diabetes which arising from an interplay of metabolic, vascular and neuropathic dysfunctions that triggered by a chronic hyperglycemia. So the pathogenesis begin with increase in intracellular glucose, which is diverted into an alternative metabolic pathway such as a polyol pathway, where excess glucose is reduced to sorbitol. When sorbitol accumulates within the cell, it causing the osmotic stress and also a cellular damage. So similarly to hexamine pathway, it diverts glycolytic intermediates into uridine diphosphate and acetylglucosamine synthesis, which alter the transcription factor that is very essential for a normal cellular repair and function. So at the same time, glucose undergoes non-enzymatic diabetic glycosylations that forming advanced glycation and products that known as AGE. So AGE contribute to oxidative stress and chronic low-grade inflammations, impairing the endothelial and cellular function. So simultaneously, it increases the protein kinase activity that thickens the arterial walls by promoting smooth muscle proliferation and white blood cell infiltrations, so further reducing the vascular compliance and perfusions. So this metabolic dysregulation is compounded by hyperinsulinemia, which impairs the peripheral nerve repair mechanism and exacerbates neuropathy. So neuropathy in diabetes is multifaceted, which is involving a sensory, a motor, and also autonomic system. So sensory neuropathy leads to loss of protective sensations, so minor injuries or pressure points go unnoticed. So motor neuropathy weakens the intrinsic foot muscles, causing deformities like clawed toes and charcot foot, which create abdominal pressure areas. Autonomic neuropathy reduces sweating, resulting in dry, cracked skin that predisposes the foot to infections. Together, these neuropathy contribute to tissue breakdown and delayed healing, setting the stage for ulcer formation, creating ulcer easily. Another critical factor in diabetic foot ulcer pathogenesis is peripheral vascular disease. So a hallmark of diabetic microangiopathy and ulcerated arteriosclerosis. So chronic hyperglycemia causes the endothelial dysfunctions and narrow blood vessels, reducing oxygen, nutrient delivery to lower extremities. Ischemia resulting from PVD exacerbate the effects of a neuropathy, further impairing wound healing and increasing the risk of tissue necrosis. These ischemia-induced hypoxia also limit the immune cell functions that preventing the effective containment of infections. The cumulative result of this mechanism is the formations of a diabetic foot ulcer, so which occur when mechanical stress, trauma, or any infections overwhelm the compromised repair capacity of a diabetic foot. So repeated minor injury, ill-fitting footwear, or pressure point caused by deformities initiate skin breakdown. Healing is delayed due to poor blood supply and oxidative stress. Once an ulcer is formed, it often becomes chronic due to infection and is creating a vicious cycle of tissue breakdowns. Diabetic foot ulcer also prone to secondary infection due to impaired immunity. So hyperglycemia comprises the neutrophil functions, including the phagocytosis and microbial killings. These immune dysfunctions allow microbial infections, often involving the anaerobes and aerobes, to thrive in the ulcer environment. So if untreated, infection can penetrate a deeper structure, which leading to osteomyelitis and inflammations of the underlying bone. In some cases, severe infections and tissue obstructions result in charcot arthropathy, a progressive and destructive process that collapses the foot's bony architecture. Ultimately, without timely interventions, diabetic foot ulcer can progress to a gangrene and necessitating amputations. Clinical presentations of a diabetic foot ulcer is depending on the pathophysiology, typically involve a chronic, non-healing ulcer on the foot, often located at over high pressure points such as the plantar surface, metatarsal head, and also heels. So these ulcers develop as a result of peripheral neuropathy, ischemic, and combinations of both. The ulcer themselves may appear shallow or deep with irregular or well-demarcated edges. Neuropathic ulcers are often painless and surrounded by callous skin with a granulating wound but unless infected. In contrast, ischemic ulcers are typically painful that occur at the distal sites like the toes and show signs of reduced perfusion such as pale, cyanotic, and cold skin. So mixture ulcer may exhibit features of both neuropathy and ischemics. So infection is common complications and the sign is as erythema, warm, swelling, coronal discharge, or fluid odor. Inflammation may extend to a deeper tissue, which leading to a cellulitis, abscess formations, or osteomyelitis. It causes systemic symptoms such as fever, chills, and malaise, indicating a possible sepsis. Patients may also display foot deformities like clawed toes and charcot arthropathy, which contribute to abdominal pressure distribution and increased risk of ulcerations. Continue with principal management of diabetic foot ulcer. It involves comprehensive multidisciplinary approach that address the underlying causes that promotes wound healing and prevent complications. So wound care is critical and should indulge regular debridement to remove necrotic tissue, slough, and biofilaments that delay healing. So these may involve a sharp, autolytic, enzymatic debridement techniques depending on wound condition, maintaining a moist wound environment with appropriate dressing such as hydrochloric alginates. Facilitate tissue repair dressing should also manage the exudate and reduce the bacterial load. Offloading pressure from the affected areas are very essential, particularly in a neuropathic ulcer. This can be achieved through a total contact casting, therapeutic footwear, or orthotic devices that will distribute weight and prevent further trauma. For ischemic ulcer, improving the blood flow is a priority. Revascularization procedures such as the angioplasty or bypass surgery may require it to restore the perfusion. So infections must be promptly identified and treated. So mild infection can manage with oral antibiotics targeting a common pathogens, while severe infection or osteomyelitis may require intravenous antibiotic or surgical interventions. Early diagnosis and management of deep infections is much important to prevent sepsis or amputations. Patient education is equally important. Should instruct on the proper food hygiene, daily food inspection, and use of protective footwear to prevent future ulcer. So smoking cessations and lifestyle modifications such as weight management and physical activity also play a role in reducing a risk factor. So let's continue to the topic of amputation. So what indications for amputations? So amputation is a last resort intervention in the management of diabetic foot complications, and its indications are typically driven by the severity of tissue damage, infection, and vascular compromise when limb salvage is no longer feasible. So one of the primary indications of the presence of life-threatening infections such as necrotizing fasciitis, spreading gangrene that cannot be controlled with antibiotic or surgical treatment. An infection extending to a deeper structure such as bone or joint, particularly when associated with systemic sepsis, may necessitate amputation to prevent further morbidity or mortality. Another medication in critical limb ischemic with irreversible vascular compromise. Patients with non-revascularizable arterial disease who develop severe ischemic pain, a non-healing ulcer or gangrene often require amputation to relieve the pain and remove necrotic tissue. So persistent waist pain and progressive tissue necrosis despite maximum medical or surgical efforts signal the need for this intervention. So amputation may also necessary for non-healing ulcer that fail conservative treatment such as an offloading, debridement, and wound care, especially when there is extensive soft tissue destruction or bone involvement. Additionally, patients with a severe charcot arthropathy that result in unstable and non-functional foot, particularly when it's refractory to other interventions, may benefit from the amputation to restore the mobility and improve quality of life. In some cases, like amputation is indicated for extensive peripheral neuropathy, causing a repeated trauma and recurrent ulcer. So particularly when these lead to chronic infections or severe deformities that compromise limb functions. So lastly, psychosocial and functional factors must also be considered as amputation may be chosen to improve patients' overall mobility and independence in cases where limb preservation would result in prolonged immobility or rehabilitation potentials. So ultimately, the goal of amputations is to prevent systemic complications, alleviate the suffering, and optimize the functional outcome while balancing the risk and benefits for the individual patients. So now, what are the level of amputation? So amputations for diabetic ulcer is determined by the extent of the infections, the ischemic and tissue necrosis. The primary goal being removal of non-viable tissue while preserving as much limb function as possible. So toe amputation is the most distal level and is indicated for a localized gangrene or non-healing ulcer confined to a single toe or its surrounding tissue. If the infections or necrosis extend to the metatarsophalangeal joint, a ray amputation which removes the toe along with the corresponding metatarsal bone may be performed. So when the forefoot is severely affected, such as in case of multiple affected toes or extensive soft tissue loss, a transmetatarsal amputations may be necessary. So this level retains some of the foot's weight-bearing functions and allow for the use of custom footwear or orthotics. So however, successful transmetatarsal amputations require adequate blood flow to the foot, which may be determined through vascular studies like ankle brachial index or angiography. So in case where the infection or ischemia involve the midfoot or hindfoot, a partial foot amputation such as a corpus and Lisfranc amputation may be performed, although these are less common due to risk of pressure ulcer and instability. For extensive disease involving the entire foot, a below-knee amputation is often indicated. This level prefer over above-knee amputations as it preserves the knee joint, which is critical for mobility and also use of prosthetic. And above knee amputation is reserved for a severe non-recurrent reconstructible vascular disease or extensive infections that compromise the entire lower leg. While functional recovery is more challenging, above knee amputations may be life-saving in advanced cases of sepsis and critical limb ischemia. So decisions on the level of amputation is guided by multidisciplinary input, including vascular, the orthopedic, and rehabilitation teams to optimize the both clinical outcome and post-operative quality of life. Lastly, we will talk about the surgical principle for amputation in the context of a diabetic foot ulcer. We aim to ensure the complete removal of non-viable tissue while maximizing residual limb functionality and promoting optimal healing. So pre-operative assessment is critical and includes evaluating extent of infections, the vascular supply, and patient's overall conditions such as glycemic control and comorbidities. So vascular studies such as a Doppler ultrasound and angiography are often required to assess the viability of tissue and determine the appropriate level of amputations. So the goal is to perform the most distant amputation possible to preserve function while ensuring sufficient perfusion for wound healing. So intraoperatively during surgery, the first principle is removal of all necrotic infected ischemic tissue to prevent further spread of infection or gangrene. So the surgeon must ensure the level of amputation is true viable blood perfused tissue, which assessed intraoperatively by checking tissue color, bleeding from a cut surface, and the viability of muscle. So layer closure technique is often employed with careful handling of skin, muscle, nerve to avoid post-operative complications. So nerve should be cleanly transected under tension to prevent the formations of painful neuromas. The bone is shaped to allow for optimal prosthetic fitting and to avoid sharp edges that may cause skin breakdown. Adequate soft tissue padding, typically using the local muscle or skin flaps, is crucial to provide cushioning and promote wound healing. Hemostasis is meticulously maintained to reduce hematoma formations, which can delay healing of or lead to infections. Post-operatively, a multidisciplinary approach is essential for wound care, infection control, and rehabilitation. So early mobilization and prosthetic fitting where applicable are encouraged to enhance the functional recovery. So patient educations on proper stump care and preventions of further complications such as pressure sore is vital. This principle collectively aim to achieve a functional limb, reduce complication, and improve the patient's quality of life. So that's all from me. Thank you.